Okay, well, thank you so much, Dr. Collier. And we are a couple minutes over time, so we're going to go directly into our next speaker. And it is my pleasure to introduce Chelsey Stillman, who is going to talk today about the ketogenic diet. Dr. Collier gave us a brief intro just now, but Chelsey Stillman is one of our longtime friends and volunteers at the Epilepsy Foundation of Colorado, Wyoming. Chelsey is a senior instructor of pediatrics at the University of Colorado Anschutz School of Medicine. She did an undergraduate degree in 2007 from CU Boulder and got a master's in child health physician assistant studies in 2010. She's been working at Children's Hospital in the neurology department ever since. She has been co-managing the Keto Diet Clinic since 2010 with several accepted ketogenic diet abstracts at the American Epilepsy Society, as well as several publications. She is and has been for over a decade one of our most dedicated and enthusiastic participants in our epilepsy camp program every summer, and is a passionate supporter of children with epilepsy. So it is my great pleasure to introduce Chelsey Stillman. Chelsey, it is all yours.
Hi, guys. Can I get a thumbs up if y'all can hear me? Okay, good. Okay, so let's just jump to it, because why wait? All right, slideshow, start slide. So my name is Chelsey. I have worked in the ketogenic diet program here for a very long time, just about 12 years coming up. And I will just start. I have no disclosures. I sort of wish I had one, but I don't. This is our agenda. Not that I kind of hate these slides personally. I feel like no one actually, we're going to talk about a lot of different things, including some of the alternative diets. So how does a child end up on the ketogenic diet? So this is an example of, this is just a case report. So we have this kid, his initials are JR. He's 4 years old. His birth history was normal. Development history was normal. Past medical history, pretty normal. He had RSV, because all kids do. Family history, child or a brother with 3 febrile seizures, and mom has migraines. In October, he had 3 convulsive seizures in the setting of fever, not started on a medication. November, he had his first afebrile seizure, an unprovoked seizure. So then his EEG was also abnormal, and so he started on topiramate. Late November 2020, he developed myoclonic seizures and jerks, as well as absence seizures. So his Topamax was increased. In December of 2020, he developed drop seizures. He was then placed on Depakote as well. And because of those drop seizures, he required that soft padded helmet. In January 2021, his seizures were occurring in 20 to 30 minute clusters. He goes to the ED 3 times. Late January 2021, Keppra is added, develops behavioral side effects, though Keppra is maximized. Parents are now reporting that he's losing skills in school. In February 2021, he's now on 3 meds. He has side effects. He's tired. He's vomiting. He has weight loss. We switch meds around. He has this diagnosis called DEW syndrome, which is has daily myoclonic and drop seizures. Seizures are still occurring, and by May, parents are tired kind of with all of the medications and still ongoing seizures, so they want another option. So anyone with a child with complex epilepsy probably feels a little bit of is familiar with this picture in this slide, because there are just so many medications sometimes. It gets very hard. So I apologize that the purples are so similar. I was really aiming for like different shades, but basically if we start like at 12 o'clock noon, who's a good candidate for the kids that are on the ketogenic diet? So who's refractory? So we use the ketogenic diet for kids that are refractory to medication. So about half, that first almost down to 6 p.m. from 12 to 6 p.m. Will respond to seizure. Their epilepsy will respond to the first medication. Now there's this other small percent that goes over a little bit to like 7 o'clock over there, where another 13% of kids will respond to a second medication. And the third or fourth is a very small portion of the population, the third or fourth medication. So you really have this chunk of the pie. About a third of kids won't respond to medications for epilepsy. So we have to think about non-medication options. And for that, we consider the ketogenic diet. So who are the best candidates. So the 2018 study or the 2018 guidelines developed or released by Hopkins said that this group of patients tend to respond the best. So we have kids with Angelman syndrome, Dravet syndrome, Deuce syndrome, or epilepsy with myoclonic atonic seizures. GLUT1, that's actually the standard of care, kids who have febrile-induced related epilepsy syndrome. And then you have like formula-fed kids do well, infantile spasms, Ohtahara syndrome, PDH, which again is actually, that's the standard of care. Tuberous sclerosis tends to have, and all of these kids have been felt to have greater than 70% reduction. Over 70% of these kids will have more than a 50% reduction in seizures. Who are other candidates? So kids so these are all kids that we think of like diet very early on, like first, sometimes first, but often like second tier, third tier. Now these kids, we tend to think of more of like third, fourth tier for in using the ketogenic diet. It's felt to be that it's moderately beneficial, whereas the others were quite beneficial. So probably around half of these kids will get a 50% reduction. So CDKL5, childhood absence epilepsy, kids with cortical malformations, epileptic encephalopathy, ESES, juvenile myoclonic epilepsy, Lennox-Gastaut, and then Rett syndrome as well, non-CDKL5 Rett syndrome. So where did this come from? Where did the diet come from? So there's actually, I had to find, this was very hard to find. So I actually found it in the New Testament, Matthew 17, 14, 21. The quote is, "Lord, have mercy on my son, for he's an epileptic and suffers severely. So he often falls into the fire and often into water. So I brought him to you, your disciples, but they could not cure him. So Jesus said to them, move from here to there and it will move. This kind does not go out except by prayer and fasting." So if you notice, they said that basically that he's having seizures and he needs to fast. Why did fasting get rid of his seizures? Well, if you stop eating, you'll break down body fat. When you break down body fat, that you will make ketones. So they found that when kids would have people would have a lot of seizures, they would go fast, they would develop ketosis and their seizures would go away. It actually was sort of like thought about to use more in medicine in the early 1900s, but then in like 1920s-ish is when like phenobarb and phosphenotoin came into favor. And then it was, as our last presenter discussed, it was Jim Abrams and Charlie Abrams who really popularized it to use for epilepsy. So it's been commonly used for a while now. So this is actually, I think it was the early 90s is when they started to, so you can see this graph is actually a graph of the publications regarding the ketogenic diet. So you can see that it comes from the mid 90s, it just became incredibly popular. People want to try to implement it because it's effective. You wouldn't study if it wasn't effective. So I am going to try my darndest to play you this. Sometimes it doesn't work. Will it work? Hold on. I'm kidding. Can I do?
Yeah, it's just an order that we need for fitness.
Okay, I will help you real quick. Here, let me actually.
Eventually, we found the ketogenic diet in the library. Put Charlie on the ketogenic diet. Seizures went away. When something like that happens to a family, there's this initial euphoria, and then all of a sudden you step back and realize it's a world epilepsy population of over 50 million people. Most of those people start having seizures as children, and only a small fraction ever find out about diet therapy for epilepsy. And I can tell you from our experience, almost as horrible as watching what Charlie went through was figuring out that 90% of what happened to him wasn't necessary. So Nancy and I figured that we had to do something about trying to raise awareness of the ketogenic diet.
Had some knowledge that this diet was probably working back at Johns Hopkins, and yet you dissuaded the Abrams from attempting it. How come?
Well, because I don't think we had exhausted all of the medical approaches yet. There were actually still other medications that we hadn't tried yet.
It's just something really,
really, really wrong. I bring my kid to you people for help, and all you do is make
Oh.
him sicker. You give him one drug, and then he needs another. Cure him of the
You
first
guys
one,
can't see this.
and then he needs another drug.
So I've
to
just
take
been
away the
sitting
side
here.
No, we can't see it.
Sorry, guys.
effects. Swollen glands.
All right. Well, you got to stare at my face for a little bit. You all can watch that video. Do you guys give out my presentation?
We're recording this, so we'll
Oh.
see your face and listen to it like quietly in the background.
Oh, you can listen to it and can't. Well, gosh. Oh, that's right, because I shared just my presentation, not my whole screen. Well,
Try again.
oh, screen sharing. Let me stop sharing, and then I'm gonna have to share my whole screen. Share screen. And then let's try it again. Oh, you guys, I hate when people do this and have technical difficulties. This is so embarrassing. Okay. Let me know. Let me know earlier this time.
Now we can see it.
Okay.
Charlie got sick with horrible epilepsy.
Got it.
All the available drugs and brain surgery didn't work to stop his seizures. Eventually, we found the ketogenic diet in the library. We put Charlie on the ketogenic diet, and the seizures went away. When something like that happens to a family, there's this initial euphoria, and then all of a sudden you step back and you realize there's a world epilepsy population of over 50 million people. Most of those people start having their seizures as children, and only a small fraction ever find out about diet therapy for epilepsy. And I can tell you from our experience, almost as horrible as watching what Charlie went through was figuring out that 90% of what happened to him was necessary. So Nancy and I figured that we had to do something about trying to raise awareness of the ketogenic movement.
You had some knowledge that this diet was probably working back at Johns Hopkins, and yet you dissuaded the Abrams from attempting it. How come? Well, because I don't think we had exhausted all of the medical approaches yet. There were actually still other medications that we hadn't tried yet.
You're so wrong. You do something really, really, really wrong. I bring my kid to you people for help, and all you do is make him sicker. You give him one drug, and then he needs another drug to cure him of the first one. And then he needs another drug to take away the side effects of that one. And another one, and another one, and another one. I mean, he has had a rash, swollen glands, a fever, constipation, hemorrhoids, bleeding gums. And he acts like a drunk, like a zombie, a psycho. And it's not because of his sickness. It's because of your cure.
So why are modern doctors ignoring this diet? Charlie's own doctor has a surprising answer.
There's no big drug company behind the ketogenic diet, and there probably can never be unless somebody starts marketing sausage and eggs with green sauce on it as a drug. You're saying that in a sense, one of the reasons that the ketogenic diet is not popular at this point is because there's not a big drug company behind it selling it to the doctors. I think that's probably true. I hate to say that, but I think it's probably true.
Johns Hopkins, they took 58 of the sickest kids, put them on the ketogenic diet, and almost a third of them had their seizures go away.
Second day of the diet, her myoclonic stopped. And we didn't even talk about it.
The 24 hours in, and my mom came in the hospital. I was so excited. I said to her, "You only have 5." And she was so excited because we went down from 100 whatever to 5.
It was phenomenal because the school was saying he was so connected, he was learning, he was engaging, and he was communicating. I'm pushing the button, to call the nurse, and I'm like bawling, I'm crying. I'm like, "Please, you guys gotta come and see this right now." And they come running in like, "What's going on? What's going on?" I said, "He just got up and went to the bathroom." "Oh, what happened?" I said, "Well, he's never done that before. This is a miracle." It was like too good to hope for. So he had 5. The next day, I think he had 2. And the next day, he had 0. Too big, too small.
Okay. Good stuff. I like that video. Gets me a little emotional every time. Anyway, so from current slide. Okay. So wait just a minute. Okay, here we go. So let's talk about the diet. So as our last speaker already alluded to, there are several different types of diet. There's a classic ketogenic diet. This is a very high fat, adequate protein. So we usually try to meet the child's needs based on weight, and limited carbohydrates. So fat as your calorie source comprises about 80 to 90%. It usually comes from butter, oil, heavy whipping cream, mayonnaise. We do meet the RDA for age and sex for their protein, and then carbohydrates kind of make up whatever else we can fit in. So typically a child on the classic ketogenic diet can eat anywhere from like 10 to 20 grams of carbs in a day. We've had kids on less, we've had kids on more. It kind of depends on their calorie needs, but 80 to 90% of your calories will come from fat. It's incredibly sensitive to carbohydrates, including those. There are some that you wouldn't think about. So there are some meats that have carbohydrates because of the way that they're processed. There are also medications and actually oral hygiene products, as well as supplements and lotions that contain carbohydrates. So how effective is the ketogenic diet? So there are lots of studies that'll tell you how effective it can be. And you can kind of read these. In 1998, there was a study that said 40% of the kiddos had an over 50% seizure reduction after 1 year, and 10% were actually seizure free. That's still about what I think we see. And then again, Neal 2008 said 40% of the group had an over 50% reduction in seizures. So it really kind of, and I would actually say these days we're kind of separating it out into like epilepsy syndrome. So we do know that there are some syndromes that actually respond a little bit better to the diet than kind of these just general epilepsy cohorts, because epilepsy is very different for each kid. And there are so many different types of epilepsy syndromes. So this is a good picture of the classic ketogenic diet. So again, 90% of your plate would be a fat source. You get about 4-ish grams of carbs and 6% is protein. So a typical meal plan for a 2-year-old might be breakfast, about 2 ounces. Breakfast would be 2 ounces of heavy whipping cream. Now you can water heavy whipping cream down to like make it the consistency of milk. It's never quite the same. You can add flavoring, stevia drops to it to make it a chocolate or a strawberry milk or vanilla milk. Some kids do just grow old of the heavy whipping cream though. You can have a 1/2 ounce of bacon and a 1/2 ounce apple. Lunch might be, again, heavy whipping cream, some cheese, a little bit of ham, and a single strawberry. Snack would be, and again, this is for a 2-year-old. So like if adults are looking at this and being like, I am already hungry. Again, this is for a child not eating, eating like 800, 900 calories a day. So a snack might be a macadamia nut or 3 black olives. Dinner might be, again, cream, chicken, butter, green peppers. Now in like way old, like decades ago, they used to recommend limiting water. We don't do that anymore. They used to recommend that because the only way that we had at that time to measure ketones was ketones in the urine. And they found the kids that drank less water had higher ketone concentration in the urine. We know now that the only reason they looked higher is because they were actually dehydrated. And we don't aim for anyone to be dehydrated. So we do unlimited water, Crystal Light, 0 carb fluids are free. This is another example. So this would be like a very basic keto meal, 50 grams of a raw egg. So on our ketogenic diet, when we initiated, we would give you a gram scale to measure these things. So this would be like a basic 101, like you would eat this in the hospital when you admit to start it. And we'll get into how that starts here shortly. So 50 grams of egg, and then you cook it. So you don't need the raw egg. So you cook it. That'd be weird. 23 grams of mayonnaise, and then 10 grams of butter. This is an example of a 4-to-1 ratio meal. This would be like someone who comes in and is a little bit farther down the road in their creativity. So this is actually, so it doesn't have to be boring. It doesn't have to be just eggs and berries, though that is a great way to start. But there are keto syrups that are 0 carb, actually 0 calorie, that exist. There's macadamia nut pancakes that a lot of our kids really like. And yeah, this is kind of how you make it. Those are the ingredients. And that's a common one we hand out. So the classic ketogenic diet, now, though this is a diet, it is not safe to do without medical guidance. So it is inadequate in many vitamins and minerals, and not often, but almost across the board requires supplementation, such as a daily sugar-free multivitamin, carnitine, a calcium and vitamin D supplement. Common deficiencies that we find and that we test for include carnitine, zinc, selenium, magnesium, calcium, vitamin D, potassium, and phosphorus, as well as fiber. So as you probably noticed, there's not a lot of like whole grains on this diet. And of course, again, like I said, fluid restriction is no longer recommended. So this is a list of the side effects. I will say that the ketogenic diet kind of offers, these side effects are worse and happen more often. On the modified Atkins diet, you tend to see fewer side effects. So on the modified or on the ketogenic diet and modified Atkins diet, they both have the same side effects, but like how often you experience them kind of depends on the restriction of your diet. So common side effects include kidney stones, constipation, high triglycerides, well, actually all of your lipid panel, decreased linear growth. So over time, kids actually tend to track a little bit shorter. If they were at the 50th percentile when they started diet, they might now be at the 30th percentile 2 years in on the diet. Trace vitamin and mineral deficiencies, acidosis, weight loss, and worsening GERD. Now, acidosis is kind of like the main driver behind what causes keto flu. Now, if you've heard about keto flu, that really just means you're very acidotic. It usually causes decreased appetite, fatigue, vomiting. In profound acidosis, which we've seen kids down in with bicarbs down in like 5 and 6 and 7, where a normal value would be like 20. We've had to get EKGs because profound acidosis can cause heart arrhythmias. So we do, again, like I said, this needs to be medically managed when initiated. Other possible but rare side effects, so osteopenia and fractures, because again, the acidosis, chronic acidosis actually lowers your bone density. Anemia, prolonged QT syndrome, and that tends to be mainly in, again, acidosis or selenium deficiencies. Acute pancreatitis, and again, that's because the pancreas is the only organ in the body that really breaks down fats. And if you're on a very high fat diet, you can ask too much of your pancreas and it can become inflamed. Low protein, and that would be kids on a very strict ketogenic diet who might not be eating all of their protein needs. And so you can find that kids get some third spacing or some swelling and edema and things like that. And a low white cell count. And that's actually something that's a little bit newer and has been verified on several studies. So how do I start the diet? So you would start you get a referral from your epilepsy doctor. So this would be our institution. I can't actually speak to like university, but this would be our way about going things. And it's not all that different from other institutions. So an epilepsy doctor would make a referral through our schedulers and say, this child would be a good candidate for the ketogenic diet. So they get in with a new patient appointment. Now in that appointment for a new patient keto visit would be, which usually is like weeks to maybe a month or so out, myself, an advanced practice provider, and a dietitian. So you have this visit. We talk about, social situations. Do I go to school? Do I split time between households? Do I avoid any meats or foods for religious or allergy reasons? We tell them the different diet options. We actually have to do several ketogenic labs beforehand. There are some disorders of fatty acid metabolism that would make initiating this diet a little bit dangerous, not a little bit dangerous, can be very dangerous. So there are labs that we'll do before starting diet that are a hard stop. We will not start the diet until these labs are done. And those labs are listed here. So some of them take several weeks to result, which is why sometimes we ask that the epilepsy doc actually orders them earlier if we're trying to get this kiddo on quickly. So why do we need to switch medications to tablets and capsules? So you can see here the difference. This is a milligram of carbohydrate comparison chart between the carbohydrate content in Abilify, for example. If you take a tablet, there are 57 milligrams of carbohydrates in tablet Abilify. If you take the liquid per single ml, and most people are on several mLs, there are 600 milligrams of carbs. Sorry, there's a little typo in the middle there, but Lamictal's, well, let's look at Keppra. Keppra has, for a 250 milligram capsule, has 0 grams of carbohydrates. Per single ml of Keppra, it has 200 milligrams of carbs. And we typically allow about 1 gram of carbohydrates from medications on diet. So it adds up quickly, especially if kids are on other medications for other things like reflux and stuff like that. So in order to allow the best bang for your buck, as well as to allow for the most amount of carbohydrates to come from things like fruits and vegetables, we do like to switch kids' medications to tablets and capsules. How do you start diets? So most centers begin the classic ketogenic diet in the hospital so that the child can be closely observed and medical interventions can be instituted. I would say that there are more and more people now starting the diet at home. The hospital admission also allows us to provide really close hands-on teaching, answer a lot of questions, assess labs daily as well. It can also be started on an outpatient basis. The potential advantages for doing an outpatient start would be, parents may not have to necessarily take as much time off work. It can be done for people that live rurally. For kids that have a G-tube or drink a lot of formula or primarily formula based, this actually would be a very good option sometimes. Across the board, we do initiate all infants in the hospital. We don't do home starts for infants less than 12 months of age because of their high protein needs, and they do not have they have a different kind of fat on their body, and they just tend to get sicker faster when they're very acidotic. This is what we do when a kid's admitted. So we admit on a Monday, we say, we see you in clinic, then we schedule your admission and say, oh, on week 3, we can fit you in, blah, blah, blah. Come in on Monday at 9:30. So while you're here, we do labs every day. We check urine ketones with every time the kiddo pees. Now that acid level, so ketones are acid in their biochemical structure. So if you remember like the pH scale, the acid base, neutral, we all like to live in neutral land. Ketones are acidic. So that's why you get acidotic when you have a lot of ketones in your body. Your body's actually very good at making ketones because it's like kind of a stress response in a time of fasting. But if you're ketonic for a long period of time, your body actually, it takes a little while to get rid of them. So you get kind of like a surge of this acid level as your ketones your kidneys start to get ready to like get rid of them. So when you're acidotic, you become irritable. You don't want to eat or drink. So sometimes we end up needing to use IV fluids. Again, because they're behind on their calories, behind on their intake, you can get constipation, nausea and vomiting. We can help with IV hydration and Zofran. Some kids will run into low blood sugar. Now, we tolerate a very low level of blood sugar in the ketogenic diet here, down into the 30s, we'll even tolerate, upper 30s, low 40s, because we have such a prolific other store of energy. So, we get called about blood sugars in the 40s, but if a kid has very strong ketosis, we say, well, that's fine because they have some sugar, but they really actually have very strong ketosis. So they aren't short on energy. They're just short on sugar. And so we don't necessarily have criteria for discharge, but one, child has to be medically stable. So we like stable glucoses as long as they're not dropping down into like 38 every other day. Their bicarbs need to be at least better. So if they drop down to 7, we need to make sure that they're closer to like 15 before discharge, and that they're not vomiting. They have to be like acutely well and accepting the diet. There isn't really a hard and fast criteria. So if a kiddo is fed via G-tube, we have a lot of formula options. So we have Keto-Cal, which is a dairy-based, and then we have this RCF-based formula, which is depending on soy versus dairy allergies. We find that kids with G-tubes tend to tolerate it better, and I'm not sure how to say this, but we can entirely control the amount of calories they take in. We can ensure that they're meeting their fluid goal. We can ensure that they're meeting their calorie goal. I will say when it comes to kids that are formula fed, the issue we run into is a lot of kids that are formula fed tend to, often are low tone or already kind of have a disrupted GI tract. So they tend to have low transit, and you can get worsening reflux, slower transit of this formula through the gut. So kids will have more reflux, more vomiting, things like that. So that tends to be our biggest struggle with our G-tube feeders. But we have formula mixtures, and if there is a dairy allergy or dairy intolerance, it gets a little concocty with a little bit of complete amino acid, a little bit of RCF, a little bit of microlipid, but it still is a formula made in the kitchen in a single container and given to the child throughout the day. So how do babies do? So if you start a baby and then they progress and now they're ready to eat orally, how do you do that? We can do that with you, right? So each visit. That's actually why we recommend regular follow-ups. One of the reasons why we recommend regular follow-ups is as the child learns to eat and progress, we can make baby food. So it would be, babies are started at a lower ratio again because of their high protein needs and energy needs. But we can do, when they're ready to eat by mouth, we can do like applesauce and butter. We can do, or, you know, like a ground meat and mayonnaise. So you can make baby foods ketogenic, and we would give you that. And then when they're ready for like a keto muffin, we can do that. So we will progress the diet with the child as the child developmentally progresses as well. So, so follow-up. So about 75% of children will respond to the diet within the first 14 days. Now that does mean that 25% of kids will respond to the diet in the coming months. So we don't give up on diet until kids have failed diet. You know, if they've been on diet for like 3 months, 2 to 3 months, and they haven't had any improvement, we will then be okay kind of calling it. Another study has shown that seizure freedom is most likely to happen the first few months, and it may occur as late as 18 months. So we actually, when you see the graph of the efficacy of ketogenic diet, it doesn't go up and then is flat. It actually improves with time more and more. So really the longer, it's not quick, but the longer the child's on diet, the more effect that the ketogenic diet can have. We do a follow-up 1 month after you start the diet, and then every 3 months for the next 2 years-ish, and then every 6 months after that. Why do we follow up so much? Because, well, one, you know, the calorie goal is a guesstimation, a very educated guesstimation, but we can go high or low. So any calorie changes often really need to happen in the first month. So also we'll do fasting labs every 6 months. We do labs at every single visit, what their ketones are, what their zinc, selenium, phosphorus, D, CMP, CBC. We do several labs. It's anywhere between 9 to 11 labs at every visit. And we do bone density after kids are about age 4 to 5, because this diet can cause low bone density. And we know that a lot of our anti-seizure drugs actually cause low bone density as well. So we will do a bone density scan. If it's a lot of their kids have low bone density, a lot of them, you know, might be not fully mobile and aren't weight bearing. So those kids tend to have lower bone density at baseline. So we just want to make sure that we're not making their bone density worse. So we sometimes we'll do a couple bone density scans to make sure that they're moving in the right direction, not the wrong direction. So there are other diets other than the classic ketogenic diet. We have the modified Atkins diet. Now we tend to use this when kids are in like, you know, when they're like 7, 8, 9 years old, you know, like deep into grade school. Now it's less restrictive than the classic ketogenic diet. It's felt to be about as effective. There are some studies that would say keto is more effective. I mean, again, like there's a million studies. So you can find studies to say that the classic ketogenic diet across the board is more effective, but there are a lot of studies to say that the modified Atkins diet can be just as effective. So on this diet, we don't initiate this on an inpatient stay. We initiate this at home. So we would still do that first visit, but then have a full like couple-hour teach with the dietitian where you just learn how to do the diet. We usually start with around 10 grams of carbohydrates in a day. And to put that in perspective, a single apple, depending on the size of the apple, has like 15 grams of carbs per day. A single glass of milk has anything, like an 8-ounce glass of milk has 12 to 15 grams of carbohydrates. So it's incredibly low in carbohydrates. You get unlimited zero carb foods. So if you want just a chicken breast, you can have as many chicken breasts as you want. It does require regular supplementations. Weight loss for this one is a concern. So I will also say, if someone's telling you that they're doing keto, they're probably just doing like a glorified Atkins with more mayonnaise. We don't weigh and measure things, but we count things in common volume. So we'll say, okay, you're allowed 10 to 15 grams of carbs per day. That means at this meal, you get 8 blueberries. You get 2 cups of spinach at this meal. So we count carbohydrates. A lot of people will think, okay, well, that's fine, but cheese is, you know, carb-free, and so is heavy whipping cream. And no, they're not, because they are dairy-based, which have lactose, which have carbohydrates. So we still recommend looking at the serving size on you know, cream cheese isn't free. A lot of people think cream cheese is also free. It is not. Mayonnaise would be free. That's butter, oil, mayonnaise, and zero carb meats, and not all meats are zero carb. So it is still hard to do. And because of that weight loss, we will often prescribe fat at mealtime. So like we might prescribe 1 to 2 tablespoons of fat at each meal. And that can be also hard for the kid to, you know, take down too. It's just 2 tablespoons of oil, or 1 tablespoon of oil, 1 tablespoon of mayonnaise. Like this one. Wait a minute. These are some examples of modified Atkins. It's hard to find a good example. So like there's the plate over here, which is there's a lot of protein. So these kids end up having some like abnormal lab values on their sometimes their renal studies that just suggest that this kid eats a lot of meat. It's basically just it's meats and vegetables and a limited amount of vegetables. So you really truly have to count the carbohydrates from the vegetables and the cheese, but it would be like a steak smothered in mayonnaise. That's not an uncommon meal. The low glycemic index diet. Now, this is less restrictive than the classic ketogenic diet. We actually don't initiate this in a lot of kids. We do have one clinic that initiates that for their kids with Angelman syndrome. But in our portion of for epilepsy, this would be like a step down. So if you've responded well to the diet, or child does respond but isn't able to tolerate such a restrictive diet, we might transition to a low glycemic index diet. Now, if someone's on 50 grams of carbs per day, we don't need to see them in our ketogenic diet clinic. We will happily give them that information and have them follow up. If they want to ask us questions, that's fine. It is allowing for low glycemic index foods. So that's basically carbohydrates with a lot of fiber, and around like 15 to 20 grams of carbs per meal. So as opposed to from a day, now you're getting this per meal, that's quite a bit more. This is a diet comparison sheet. Now, you can kind of see that the classic ketogenic diet is 90% fat, 6% protein, 4% carbs. And then the lower your ratio. So we didn't talk about ratios, but let's do it now because now's as good a time as ever. When you're deep into keto land and Googling what keto is, you'll hear and like mention people talk about ratio. Now the ratio is like the volume of the diet, the miles per hour per diet, or like the dose of the diet. And that is the 4:1 is parts fat. So it's a ratio of portions of fat compared to non-fat. So basically protein plus carbs. So 4:1 would be 4 parts fat to 1 part not fat. 3:1 is slightly more liberal, 2:1 and 1:1 and so on. So you can kind of see that the modified Atkins diet doesn't look all that different from a 1:1 ketogenic diet ratio. They do get quite a bit more protein though. And the MCT oil diet is also something we do, tends to be not quite as often. MCT oil is an oil that is very ketogenic. It's basically coconut oil, to be frank. And it's a very ketogenic oil. The hard part is that coconut oil taken over a long time really does affect your lipid parameters. So we do, I personally find that we end up having to take kids off of that from time to time because they just have sustained elevated high cholesterol after a period of time. The other thing is you'd never guess the things that have carbs. So like, if anyone remembers lip smackers, like those things have carbohydrates. I took off, I don't know how I'd feel about like making someone change their deodorant unless it was like a very sweet smelling pungent deodorant that smelled like flowers or cologne, and they might be actually sweetened with sugar. But there are a lot of things that we would give you recommendations on. It's nothing stuff, that you wouldn't find at King Super. So if you actually have like a very sweet smelling lotion and you rub it all over your skin, you can absorb enough carbohydrates through your skin to throw off your ketone levels. So we will give you recommendations. It's usually just like unscented, unflavored stuff. It's nothing crazy. You can find this all at like King Supers and Safeway. But like toothpaste, we're pretty particular about as well. I think that's it. Oh my gosh, is that it? That's the whole thing. And that's all she wrote. 17 minutes to spare. I am happy to take questions.
Thank you so much, Chelsey. That was amazing. And I really appreciate that. And we've got a lot of questions in the chat, actually, and I'm sure we've got some questions that people want to ask you live, but I'll just start with a few that are in the chat, if that's okay.
Yeah.
One of the first ones is, can the keto diet or any of the modified diets work better with anti-epileptic drugs, or are they just done by themselves without medications?
So yeah, that's a really good question. So I don't think there's any like data to say that they work like symbiotically with medications. Now, when we start kids, we won't change medications for usually like 6 months if you're on medications, because then you're adding too many variables, right? So if you decrease your Keppra and you start diet and seizures get worse, was it diet? So it's very relatively rare and unheard of to make seizures actually worse when you start diet. But we really just want to keep things simple and know what diet does in isolation. So we tend to not make changes for about 3 to 6 months at least, unless there's like one med that's like really causing a lot of side effects, we might drop down that earlier, but we tend to not make medication changes very early on.
Now, we know that you are a pediatrician and you work at Children's Hospital, but there is a question about how this works for adults. Can you speak to that at all?
Yeah, so adult data is also, oh my gosh, yeah, so it does work as well. I think we have more, they tend to do a lot more modified Atkins diet, though as we have transitioned more kids to like university, I know that they have, in the last several years, they've really ramped up their program. They've got a very prolific program over at university and have done a wonderful job. They will continue to do G-tube feeds for adults that require G-tube keto. I believe the numbers in adults is about as good. In kids, I would say I'm not as versed in that. So that's a really good question for adult neurologists. I imagine it would probably be around a 50% reduction in seizures as well. But we tend to, look more at the kid data.
Right.
Then the adult neurologist wants to chime in, feel free.
And we know that you're an epileptologist, but we also have a question about whether keto is recommended for type 1 diabetics. So I don't know if you can speak to that disease state.
Yeah, so that's a really good question. So they're looking at it. So one, I'm not an epileptologist or a pediatrician, I'm a PA, but thank you for all the compliments and the assumed prestige. The ketogenic diet. So yeah, I've had a kid who had type 1 diabetes, who also had epilepsy that we used keto on, and it worked really well. So the thought being that you give someone an alternative energy source, and they won't have such wild fluctuations in their blood sugar levels, or if they drop, they have another energy source. And the keto did well. I mean, I think he grew tired of it like any other 16-year-old teenager. But it is being looked at now. Do I implement that for kids for just diabetes? No. I think that's a really good question for someone in endocrine. We have been approached to do that for people in that state, but given our bandwidth, we haven't done it. So I think that there are people who are implementing it or doing like a low GI diet commonly for people with type 1 diabetes.
Great. The question is, what kind of carbohydrates are allowed?
Oh, any. I mean, it really doesn't matter. It's just it's the number. We just pay attention to the number. So if you want your carbohydrate to come from one slice of a banana, which is a very high carb food, you can have that. Or bang for your buck, you can get like 8 or 9 blueberries. You could have a eighth of a piece of bread, or you could have 2 cups of spinach. So we just tend to say fruits and vegetables or high fiber foods. But in all honesty, we've had kids that will say I just got to have a tortilla chip, and we're like, you can have one, and that was it. That's all the kid wanted, and that was great, and that sufficed his need. Or you get 1 teaspoon of beans, and that was it. And so it really doesn't matter, to be honest. It's just sometimes having a plate that's very full of spinach is a little more enticing than 1 chip and 2 tablespoons of mayonnaise.
With LGS, would you say in general to go right to keto or to try the easier modified Atkins or low glycemic?
I think that I would personally probably do a ketogenic diet in a kid with Lennox-Gastaut syndrome. I think because it is such a profound epilepsy, I think I'd do a kind of a go big or go home approach. I think my opinion would be, and then, talk to your epilepsy doc about it, but I think I would consider doing depending on the age of the child or adults, doing a, I would do a full keto. There is some data, again, it's mixed. So you can find data to support that starting a high ketogenic diet ratio at the beginning and that flood of ketosis at the beginning is more helpful is more anti-seizure. But then you also will find data that says, well, at 2 months, even if you start low and slow, you'll have the same efficacy. So you can find the data that exists either. But we tend to say, if you're willing to do it, start more restrictive. And then as you loosen up, you become very grateful for now 14 blueberries. So I would say go big or go home at the beginning.
So in what cases or scenarios does epilepsy disappear forever with use of the keto diet?
Yeah, so there are some syndromes. It's really variable. So I would still say that 10% rule of 10% of kids will be seizure-free on diet. It's our kids with myoclonic astatic epilepsy tend to do the best with this. It's actually first line. That's kind of that and like GLUT1 or PDH. If you have a metabolic condition where you don't make glucose appropriately and your brain is kind of low on glucose, and that low energy state on your brain is not good for you, so you have seizures. So there are places where you can actually leave seizure-free, and it's almost like the standard of care. In those three circumstances, we'll start it out the gate first and foremost. Seizure, the rest of the kids, it's kind of hard to predict who's going to be the one that responds so well. And it's a little less common to be seizure free when you have things like Lennox-Gastaut syndrome or CDKL5. But we do see like fewer seizures, shorter seizures, able to take away a medication, which is meaningful. So, but I will say those three particular syndromes it's like very common to be seizure free.
And I guess the next question is kind of the same thing as data on those that start with keto and then stop the diet. Do you see seizures coming back with the same frequency or the same, is there data on changing types of seizures or anything like that?
Yeah, it typically, it doesn't necessarily change your epilepsy. So if it worked to control your seizures and you stop the diet, your seizures will probably come back in the same way they presented. So they probably wouldn't, it's less it doesn't necessarily change your epilepsy. It might change your seizure control. But if it worked for your epilepsy, then I would suspect that your seizures would come back when it stops. Although if it stops before like the 2-year, but we do see, just like meds, we don't know how kids' epilepsy progresses. So if you go 2 years seizure-free and we wean diet, it's just like a medication. If you're 2 years seizure-free on a medication, your seizures may not ever come back, and it's possible. But we would do a wean over a slow period of time, go to like a 4-to-1 to a 3-to-1 to a 2-to-1, then like a modified Atkins diet. So it's relatively variable, and it kind of depends on why you come off. If you come off 3 months in after you started diet and you've only been seizure-free for 3 months, would I suspect you remain seizure-free? No. But if you've done like 2 years of seizure freedom, I have a lot of hope that the child or person would remain seizure-free.
Does keto help with focal seizures?
It can. So it would be in my slides, it would be in that group that would be less of there's a 70% reduction in seizure, or 70% of kids had over a 50% reduction. It would be in the group that's like 50-50. The thing with focal seizures, if you have a focal part of your brain that is causing those seizures, the ketogenic diet doesn't get rid of that part of that brain. So if that part of that brain is still either injured or has a malformation or is epileptogenic in some capacity, it's not going to get rid of that, though it can raise your seizure threshold and reduce seizures. It doesn't necessarily get rid of them. So people may have fewer seizures while you're on it. Sorry guys, that's my timer to remember something that I am hopefully not going to forget. But yeah, I think if you had focal seizures, again, I'm going to be my own devil's advocate. If you had focal seizures and you were one of that 10% that was seizure-free on ketogenic diet, I would assume, just like a medication, that I would maybe try to wean you and hope that you remain seizure-free. So it's pretty variable across the board, but it would fall into the less likely to be a slam dunk seizure-free on diet.
I think that was all the questions that came across in the chat. Does anyone else have questions for Chelsey? Okay, another one in the chat. Are there guidelines for generalized seizure disorders as far as diet is concerned? Am I correct in my understanding that medical keto diet is not necessary, but are any of the principles applicable?
So I guess I might need a little more context to the question. In terms of guidelines, like when would we do diet? If it's like a JME or a childhood absence epilepsy, it would still be probably a case where you'd fail to meds. Now we have guidelines at our hospital as to when do you talk about it. We would probably start talking about it after 2 failed meds. I'm just thinking in like the most common types of epilepsies being like JME and childhood absence epilepsy. Because again, this isn't a low risk diet. So prolonged QT syndrome can be fatal. Pancreatitis can be fatal. Chronically low carnitine can actually cause cardiomyopathy and cause severe heart problems. So it's not It's not benign. And so we don't make it the first line for those kids when we have other medications that we feel like may actually have a better side effect profile and can cause seizure freedom. Now, if seizures aren't controlled and you fail 2 meds, we would probably introduce and talk about diet relatively soon, after failing 2 meds. But there isn't like in our hospital for those 2 syndromes, you have to have failed 2 meds.
Does the modified Atkins diet carry those same risks?
Yes, less. You get less acidosis. You can still have low selenium. And pancreatitis is less because it tends to be less fat, but they carry a lot of the same risks. They just tend to be less severe. And my fear with modified Atkins, though, is that because it's a slightly less restrictive, it feels less medicalized. I hate to say it, but I find that patients are a little less compliant with their supplements on modified Atkins. So you see that people following up aren't taking some of their multivitamins, and you'll find like low phos and trending low selenium, and those are not good things to be trending low on. And so we still take the follow-up, and weight loss is a big issue. So we still take all of those the supplements and things like that very seriously. Good questions.
Anything else for Chelsey? Okay, well, Chelsey, thank you so much. So much great information. This is obviously a really important topic, and we appreciate your time and your expertise. We've got 4 minutes before our next topic, so we're gonna just give everybody a few minutes to just get up and stretch your legs and I don't know, grab a snack out of the fridge before we have our next speaker, which is going to be Dr. Ed Ma talking to us about canine seizure detection. So I'm gonna just put the brakes on for a few seconds, and we'll be right back with you at 12 o'clock sharp.